I appreciate that you guys have the ability to have everybody come here and listen to this this great interdisciplinary team, and so we could really talk about the kind of the basics of gynecologic cancers and kind of I just kind of want to give everyone an introduction to gynecologic malignancies and the process that I've seen from my standpoint over the years in terms of how patients are from the start diagnosed, how patients are treated, where patients go after they're treated, and the team members that are involved in really the whole process of their care. And I think that roadmap will help give everyone a little bit more comfort in their treatments and in their journey with their gynecologic cancers. So as Rachel had stated, I am an assistant professor at Yale University, and I've been here as an attending for many years, and I'd like to continue that because I have many research ideas and projects that I'd like to continue. And so we can start with the introduction of gynecologic cancer. So gynecologic cancer is a rare disease, and it does on a yearly basis afflict about 100,000 women in the U.S. per year. And it is, fortunately, it is less common than breast or colon cancer or a number of other types of cancers. But it is a dangerous cancer, and it does bring on a lot of issues for a lot of people in terms of families can be really hurt from this when the matriarch of the family contracts ovarian cancer, uterine cancer, cervical cancer, and it really does change family dynamics, whether or not it's talked about or not within that family. And because it's a gynecologic malignancy, it isn't talked about as much as breast or colon cancer. And it's something that we need to change. And in fact, we even need to change it with insurance companies. It's my plug to really push insurance companies to do a better job of helping out women with gynecologic cancers. I think that's not spoken about enough. There are millions of survivors of gynecologic cancers in the U.S., and that's really a testament to groups like this who have really pushed the boundary for early diagnoses, screening, really pushing for clinical trials, and this has been a game changer and really has led to a lot of these advances. And almost on a monthly basis, I have to tell you, there are new treatments that come out and approved by the FDA and approved by insurance, and so we've really seen a lot of headway, even in the last, I have to say, 5 years, and it's very, very impressive. And I think a lot of that has to do with groups like this, again, really bringing to the forefront the issue in gynecologic cancer. And so, I was going through the CDC website, and actually this came up, and I think that this is a timely series, I guess. And so it's really talking about having women kind of speak to their gynecologist about the symptoms that they're having, and in this case, it's not just about cancer, but about any of the symptoms. And I think that's really important, because I think a lot of times the symptoms that you can get from ovarian cancer, uterine cancer, cervical cancer, they can be very non-specific. And so the most important thing is to talk about it. And the best place to talk about it is at the gynecologist. The next best place is at any of your physician's offices. But I think this series, I haven't seen it, but I think probably it's helping to get people to talk to the gynecologist instead of kind of keeping quiet about symptoms that they may be having. So the gynecologic cancers that are really the most common are uterine cancer, ovarian, and less common cervical, vulvar cancer, and probably the least common is vaginal cancer. Those are really the most typical cancers that we see, the top five. We also see trophoblastic cancer. That is a little bit more rare and not really something that I will touch on in this presentation, but it does exist, and I want to at least make sure that we have the name out there so that we can recognize it in the future. And so the next slide is really kind of the nuts and bolts of a single cell in our body. And that is, let me see if I can get a pointer here. I think I can. And that's really highlighted here. That's a single cell, and in this type of cell, these are like any cells in our body. They have DNA that's shown here that can gain mistakes in their base pairs here. And this is really the blueprint for how the cell is going to work. And any pathway along here, there can be any mistakes. And mistakes in that pathway can take a normal cell, seen here, and turn it into a cancer cell. And the reason why that's important, not to scare anybody that there's many places where there can be mistakes, but rather so that everybody understands that there's many places where we can work to fix these cells, and also work to identify cancer early. If there's an early mistake in one of these areas here, that's something we can use in the future to try to predict or identify people before they go from a normal cell that just has a mistake in their DNA to an actual cancer cell. So I think that I wanted to give you the background here about why it's important to talk about the DNA and the genetic makeup of the cell, because there's a lot of therapy now that's based on that. And so here we just have the normal cells going through phases of dysplasia, which means cell abnormality. And that's important. I wanted to bring that word up because it's a word that maybe people have heard here. And it's a precancer. And there's different grades of dysplasia, but it's a precancer. So in general, people will come to my office and they'll have been diagnosed with dysplasia, and it'll sound like that it seems to them to be cancer, but it may actually be precancer. But it can progress to cancer, and that's why we want to make sure that people understand that what dysplasia is versus cancer. Now, cancer is a dysplasia with invasion, and so that invasion you can see here coming through. So that's just some nomenclature there, and here I just wanted to talk about the cancers: the uterine cancer, ovarian cancer, cervical cancer, vulvar and vaginal cancer. Those cancers, when we talk about when they're first diagnosed, we have to understand what stage they are. They could be early stage, which is generally stage 1 and stage 2. They could be a more advanced stage, stage 3 and 4. Now, stage 1 generally can be fixed or cured with surgery, and generally people have a good outcome from that. And we measure that outcome by 5-year survivals. And the 5-year survival is important to understand really what our chances are for doing how we do with our types of cancer. And so stage 1, generally people have a good 5-year survival. And of course, as we go down the line here, when we get to stage 4, the survival at 5 years, the percentage of people surviving at 5 years with stage 4 cancer is a bit lower, something around 40 to 50%, as opposed to in stage 1, the percentage of people surviving 5 years is about 90%. Then we also have something called grade, and that's how the cell itself, how it looks, not where it's gone, but how it looks. Is it a little bit more aggressive, which is grade 3, or is it a little bit more slow growing, like grade 1? And so those are two very important aspects to all of the cancers that we talk about. And so it's important to ask your physician about what's your stage and what's your grade, because that's the first thing that we need to know to be able to understand how to treat it, and how overall you'll do. And again, the stage for uterine cancer and ovarian cancer and cervical cancer is generally we talk about a spread to, this is something called the abdominal cavity here. It's generally a spread within the abdominal cavity. So we have up here, just, we can barely see it, it's the edge of the liver. And here we have the edge of the stomach. This is the fat pad around the stomach, which maybe some people have heard about for ovarian cancer, maybe uterine cancer. Then we have the intestines here, the small intestines are in here, uterus is here. And so what we understand is that sometimes with uterine cancer, this can spread to the abdominal cavity, same as ovarian cancer, that can spread to the abdominal cavity. And cervical cancer can as well. It's a little bit more rare to see that. And here we just have the lymph nodes that are kind of highlighted in green, just to show you where the lymph nodes sometimes are that get also can get cancer within them. And so the symptoms really, when we first are diagnosing gynecologic cancers, are very vague. And I don't say this to scare anybody, because I know we all are when we've been diagnosed with cancer, we're all really thinking about what are the symptoms that we could be having. But it's important to still keep these in mind. But if they're not consistent symptoms, then it's less likely that we have to worry about them. If they come on for a couple of days and go away, then that's something that maybe it's not something we have to really worry too much about. Still talk to your physicians about it. But if they keep coming back and they stay persistently, then that's a problem. Now, bleeding, that's the caveat. Bleeding, no matter what, any vaginal bleeding, if you're postmenopausal, that's a big deal. That has to be evaluated. Or any abnormal bleeding in somebody who doesn't have a regular period, that's also abnormal. Same with discharge, vaginal discharge. These bloating, nausea, that's a little bit more vague, but still pay attention. Again, if it's persistent, you have to let a physician know. Early filling, you go to eat and you can't eat as much as you used to be able to, particularly if you're having weight loss, you're having early filling, and also bloating. Those constellation of symptoms altogether can be concerning and need to be evaluated. And changes in bowel habit. Now, the evaluation is pretty straightforward. Usually it's just a quick CT scan. I know it's less than ideal to have to go for one, but it's a pretty straightforward scan, and same with ultrasound. And so if you talk about these symptoms, it's not a long, laborious process. It's really just a CT scan or an ultrasound to figure out what might be happening. So it's better to talk early about these things and go for these CAT scans. Even if you've already been treated for cancer and it's been years and years and years, still bring these symptoms up, and it's easy enough to get a CAT scan. So for the initial diagnosis, we usually biopsy the uterus, cervix. If it's vaginal cancer, we'll biopsy the vagina. If it's vulvar, the vulva. The vulvar cancer is on the outside of the vagina. The vaginal cancer is obviously on the inside of the vagina. And if there's a mass or in the abdomen, we can biopsy that if it seems that there's no pelvic masses. And in general, sometimes when there's an ovarian mass, we can't biopsy that because we don't want to disrupt the ovarian mass. We want to keep it intact. And if it's just an ovarian mass, we might just say we can resect it and get the diagnosis. And that's generally what we do to diagnose an ovarian mass, or if there's any vaginal bleeding, the uterine biopsy or cervical biopsy, and so forth. The treatment after we have a diagnosis, after these biopsies, is generally surgery. We can do minimally invasive surgery. We can do open surgery. And that really depends on that type of cancer. So for each type of cancer, it's a little bit different. And we have many studies to tell us which modality is better. We then can do chemotherapy if we need to up front, if it seems that it's advanced disease. If it seems that it's early stage disease, we usually do the chemotherapy afterwards. Some types of cancers, if they're early, we don't have to treat with chemotherapy. Radiation is a similar kind of mainstay where we don't always have to use it, but if we're going to use it, it'll probably be in cervical cancer or uterine cancer. We don't usually use it in ovarian. Sometimes we use it in vulvar cancer or vaginal cancer. Things that are important, you need to ask questions about these things to your physicians, and you shouldn't feel bad about asking questions in the visits. And it's our job to educate people, and really we're teachers more than anything else. And I think that it's important to remember that, and to really advocate for yourself too, and bring a person along so they can also listen to what the physician has to say. And if you want to record what the physician's saying, if you ask the physician, I'm sure they would be okay with having it recorded so that you can go back and refer to it. Now, some questions that I think are important, really, when you're first diagnosed. First and foremost, what's the stage and what's the grade? Now, they might not be able to answer the stage yet, because it may be that, like with uterine cancer, you can't get staged until you have surgery. And so that's okay if they say they don't know, as long as you all have a plan to kind of figure it out. And so that's an important thing to get right off the bat: stage and grade. And then, when do you start treatment? And sometimes there's a delay in treatment, and it's not really a delay. It's because you have to get surgery, or you have to have chemo, and then you have to have surgery, but you need some time between chemotherapy and having surgery. So maybe you won't know about much of the kind of the stage. And the other interesting thing is that if you get chemotherapy up front, you may not have a stage. It might be just advanced stage for right now, while you're getting chemotherapy before surgery. You want to know about the length of treatment. You want to know about the symptoms that you'll have when you're getting chemotherapy. You want to know if there's any maintenance therapy that you could get, or any targeted therapy that you could get. Sometimes that can't be upfront with chemotherapy, but you got to ask anyways. Make sure you ask about targeted therapy. And it's not being annoying, but it's important, because you got to, again, advocate for yourself. And there's so many changes that are happening so quickly. It's hard to say whether, within a couple months, it may be that there's more targeted therapies. So be sure to ask that, whether it's a recurrence or the first time. You need to make sure whether or not you need genetic testing. I would advocate for people just to ask your physician. I mean, you don't get genetic testing for cervical cancer or vulvar or vaginal cancer, but sometimes uterine cancer, and always ovarian cancer. So I think you wouldn't go wrong if you asked. Ask if they test the genetics of the actual tumor. The genetics of the tumor might be different than your own genetics. They're two different things sometimes. So don't be scared to say, hey, what about the genetics for myself, but also for the tumor? And also be sure that you don't always have to follow the exact regimen of the chemotherapy. It's good to stick pretty close, but if you want to take a 2-week vacation, and be sure to ask your physician if that's something that you might be able to squeeze in. That's in my opinion, totally fine. And who to call if you're having side effects: fellows, nurses. What's the number? Who do you call late at night if you're having issues? And you should also know that you're not going through this process alone. There are many patients who've gone through this process. There are many physicians who know about this process that can help educate you. I mean, obviously, you guys have already taken the first step in coming to this meeting, and you understand that this isn't a process alone. I think, what makes me sad though, although maybe it's a personal preference, sometimes I have patients that don't want to talk, want to come, or go to groups and see that other people are going through this. And that's your own personal preference. And that if that's a preference, then that's totally fine too. I think that though these groups really help people. And also you should know that there's a whole team. Social workers are very important in our practice here. They help us have discussions about end of life. They help us have discussions about what to do for patients that are having a lot of pain and issues with chemotherapy. They help us integrate in issues with insurance companies, and they can't be kind of applauded enough. And palliative care for pain control, get them involved early. It doesn't mean that you have to go to hospice if you get palliative care involved. Palliative care is very helpful with pain control. And radiation oncologists obviously are good for us for radiation aspects. We all work together with the medical oncologists as well as physical therapists. And then we also like to refer to genetic counselors, particularly for ovarian cancer, sometimes for uterine cancer. And so just to let you know that we have a really robust team around the patient. And so I just wanted to remind you that you know, it's really important to speak up about these things and really advocate for yourself. And that's how I'd like to end it. I'm sorry if I went over. If you guys have any questions, I'm happy to answer.
So we'll be joined next by Aimee Sachs, MSW, Sharsheret, California Support Program Manager. She's a graduate of Washington University in St. Louis and the UCLA Luskin School of Public Affairs. Aimee assists in the delivery of Sharsheret's cancer support programs and coordinates tailored support and resources for people living with and at high risk of developing breast or ovarian cancer. Aimee, thank you so much for joining us from LA. We are thrilled to have you here and really excited for you to piggyback onto you know, the presentation we just had about the medical end of things. So thank you so much.
Absolutely. If they can see anything.
Absolutely. No, that was really a perfect way to start. Thank you so much for having me. And thank you, Dr. Altwerger, for the shout out to social workers and what we can do. You know, helped get this started off right. So, oh, hold on. I'm having trouble. Okay, there we go. So I'm going to go quickly as possible because I know we're a little over time. So if you have questions, you know, we're going to have a Q&A at the end. So definitely save them or put them in the chat. So Sharsheret provides free, confidential, and personalized support to people, you know, across the country and even some people outside of the country. Our focus is on ovarian cancer and breast cancer. However, we help people with all gynecological cancers. And honestly, I spoke to somebody last week with laryngeal cancer. So if you know anybody looking for support with any type of cancer, or you are somebody with a different type of cancer, please feel free to reach out to us. We are a Jewish organization and proud of that, but we serve everybody regardless of background. So that shouldn't be a deterrent either. There are lots of different types of social workers. You might come in contact with a social worker at the hospital or at your doctor's practice. There's a lot of overlap between what those two, you know, settings of social workers would do. They also might be at a, you know, cancer center, you know, an integrative medicine center, something like cancer support communities or Gilda's Club. You know, the ones within the hospital or your doctor's practice, you know, can really help you with understanding how the hospital works, how the practice works, what to ask the doctor, how to get in touch with the doctor. They might be able to help with insurance and local resources, financial assistance, transportation, those types of things. Calling a Sharsheret social worker can kind of fill in the blanks. One person once told me I was her cancer concierge. She could call me with any questions, you know, and kind of try to think of social workers as just someone who can help. You don't need to reinvent the wheel. You don't need to become an expert. You will become an expert in the type of cancer that you get the diagnosis for. But we're here for that. You know, we're here to be your first stop before Google, because we've probably already Googled it, or we probably already have a resource list for whatever type of resource you're looking for. So, you know, here's some examples of things that you can ask your social worker. Certainly, we will tell you that's a question for your doctor, or that's a question for so-and-so on your treatment team. But sometimes asking for a question, you know, or clarification about something that somebody on your treatment team said, sometimes people come to me with that. And I do know, you know, what kind of side effects they might, you know, be expecting, or the kind of way that side effects can ebb and flow. And I have tips about, you know, kind of different questions they might have. So you can always bring those to us. Discussions about decision making, right? There's so many decisions that you have to make once you have a cancer diagnosis. And, you know, so often you'll come to a social worker with, I'm trying to decide, my doctor's telling me it's my choice. I wish they would just tell me what to do, but they won't. And a social worker should never tell you what to do. It's our job to help you decide what's best for you. And, you know, whatever the issue is, whether it's, you know, my sister said this thing and I don't know how to deal with it, or I don't know what to tell my work, or I don't know what to tell my kids, you know, we're here for all of that. So certainly I'm not a marriage counselor, but I end up having those types of discussions every once in a while, and I'm happy to. And then, resource referral. That's really what social workers often excel at. So, resources like support groups, counseling, financial assistance, all the things that you see on the screen. We're also often here for your caregivers as well. Sharsheret has programs for caregivers. I talk to caregivers, and we use the term caregiver very loosely. I think the term sounds like someone in the home, emptying your drains and bringing you food and things like that, taking you to the bathroom. That's not what we think of as a caregiver. That might be a caregiver, but anyone who cares about you is a caregiver in our mind. So that person might be in the home with you, they might be across town, or they might be across the country. We're here for them, and certainly other social workers you come into contact will be as well. Integrative medicine is something that we're often discussing, whether it's nutrition or fitness or mental health. This whole body approach is really, really important. We know that when non-medical needs are met, the medical outcomes are better for people. So, nutrition, there are so many theories out there. You have to be really careful. Only trust a registered dietitian. If somebody just calls themselves a nutritionist, that means they're probably not actually licensed like a registered dietitian would need to be. And Sharsheret actually has a program where we can match you with a nutrition coach or a nutrition coaching program. So you can definitely reach out to me if you have questions like that, but you could also ask your hospital social worker, because your insurance might cover a registered dietitian that's within your hospital system. Fitness can be something that seems so daunting to somebody going through cancer treatment, but actually even just getting up and walking 10 to 15 minutes a day is proven to reduce your cancer-related fatigue. So it is important, though I know sometimes it feels daunting, and if it feels too daunting, it just means maybe don't let people fill up your water all the time. Go walk over to fill up your own water. Things like that can actually help boost that. And then, of course, mental health, whether it's mindfulness or counseling or whatever it means, you deserve the support and you need the support. It's not letting me navigate. Okay. So Sharsheret was actually founded as a peer support program. Now we have lots of other resources too, but it really highlights the importance of peer support, mentoring, support groups, because social isolation, which we have more than ever now during the pandemic, is a big problem with cancer. It is so hard to feel like people really understand what you're going through, because they don't. And we know that this type of high levels of stress, lead to lower quality of life and faster disease progression. But the thing that is most hopeful to me is this study that I'm quoting on the page showed that one of the factors that helped people is just seeking social support. So not even getting it. Once you decide to take care of yourself and seek people out to help, that helps. So Sharsheret can help in lots of ways. Please, don't hesitate to reach out to me or through our website. We have all these different types of resources that we can mail to you, resources over the phone. We have a genetic counselor, resources for kids, family, everybody. So like they said, they'll send out my contact information, but that's that for me. Thanks.